I'm curious to hear which native lands you all currently located or living at. And I'll add in the chat a website or a phone number that you can figure out which native land that you currently are living. So for example, I live in the Chechen and Fernandino Tataviam lands, which was colonized and is currently renamed to Santa Clarita, California. And if you've heard about Santa Clarita Diet from Netflix, we are named after that. And we are north of Los Angeles. So definitely take some time to figure out which native land in alignment with equity, and let us know in the chat where you're located. So for the purpose of today's event is twofold. One, I want to walk you through the COVID-19 communication toolkit, which comes from a health equity lens, and the historical context behind it, so you understand how this applies beyond design and research. And then the second part is to also walk you through evidence-based engagements that we've done, where we applied principles from the toolkit into our engagements, both on the local and state government level, but also with NGOs and nonprofits. Awesome. I see a lot of you have been finding out your native lands. That's one. So our discussions will roughly be 30 minutes, and it'll be pretty informal, where I'm going to show you a bunch of examples and the framework behind it, where we can take it off from design, research, and even data collection and analysis. And then I'll leave roughly around like 10 to 15 minutes at the end for a Q&A. There's a hard stop within roughly 40 minutes, so we'll stop at 4:45 p.m. PT, and then we'll head off after that. Cool. So I'll go ahead and share my screen and I'll go off camera. Okay. And I'm confirming everybody can see my screen. So I'll go ahead to align first on definitions. Does anyone see this by any chance? There's a image on my screen. It's a cartoon of an apple tree, and it's a reference to Shel Silverstein, the Giving Tree, which isn't without any controversy. And the first image shows inequality, where one person has access to the apples falling from the tree, but one person doesn't. And then the second image is about equality, where both people are given ladders of equal height. And then the tree that leans to the left is making the apples more accessible to one person, not the other. And then you have the third image, which represents equity, which is why we are here today. It's a person on the right side of the tree is given like a tall ladder to access the apples, while the person on the left has a shorter ladder that allows them access to the apples. And then finally, which is our ultimate goal of any government infrastructure, is justice. That's where we see that the tree is actually straightened. So you're removing any types of barriers for the person on the right so that they no longer need a tall ladder to access the apples. So health equity in general means that we have the personal agency and fair access to resources and opportunities that are needed for ourselves to get the best possible physical, emotional, and social well-being. But the opposite is also true. Health inequities is also the preventable differences in health outcomes, and they're typically linked to what we call social determinants of health, which is social, economic, and environmental conditions. And I want you to keep that in mind, preventable differences, because that's what a lot of what my teams have done in our government engagements, is that we wanted to treat these types of preventions before they even happen. And we've seen that the pandemic has exacerbated a lot of inequities. So there's a lot of language barriers, digital literacy levels, and even broadband access in rural and remote areas where people weren't able to book vaccination appointments and can't find vaccination locations, which are two different things. So who's typically excluded in these types of crises, pandemic or not? It's typically seniors, remote and rural, women, immigrants, also disabilities, racialized, you have indigenous, and also those with low literacy and low income, and LGBTQIA. And the landscape for government, when I first started as a technologist in resident in January this year, the landscape for governments and local grassroots orgs' response to COVID-19 was very, very different and evolved dramatically in the past 6 months. So January till March, the focus and the shift was on increasing convenience. So a lot of latitudes that I was working with teams was about how easy it is to access vaccination appointments and locations. Now the focus is on increasing confidence and social norming. So reducing suffering and structural barriers for a healthy life during the pandemic. And that has been also the focus for a lot of these pop-up clinics that you see, community vaccination events, but also ones that were with faith-based organizations and even ones that are provided by the state. So we acknowledged really early on in my teams that any work that we do that falls under design, research, and communication, we realize that design in itself can be inherently inequitable in itself. And it fails to actually address a lot of the root causes of inequity, and sadly can also produce inequitable power relationships. So the way that we come in, whether you're a designer, developer, or whatnot, we all have our own biases and assumptions, and that can potentially reproduce inequitable power relationships. So there's a Venn diagram here on my screen that highlights essentially that oppression is a system that's built into our daily lives, and that stems beyond individual act. So one thing that I realized very early on, that I'm an extension of government services as I work with my government partners, and that means an extension of their own realities and their own histories of inequities that come into place. And so with that being in mind, one of the core things is to focus on noticing oppression, how it affects us, and that we have the opportunity to make our design, research, and data work to produce greater equity. And so this comes into mind, this main question that I wanted to focus a lot more throughout the time in my residency, about how do we not just design, but also research, collect data, develop softwares and APIs to eliminate health inequities and oppression for COVID vaccine distribution, especially in historically low vaccinated populations and geographies. That was one of the core metrics and outcomes I wanted to focus on. And that means bringing in equity-based design into the process and practice that generates self-awareness, so that it liberates designers, developers, researchers from habits that perpetuate inequity. But it also means that I wanted to focus a lot on decision-making and frameworks that shifts the relationship between people who hold power to design and develop and those impacted. And I wanted to create conditions for collective equity. So this cues into a health equity framework that we built into our toolkit, and I'll show you an example of what we've done. That the health equity framework, or HEF, is actually one that was created by ETF. It's an organization that does a lot of childhood education and equity for children and youth, and it has 4 spheres of influence. The first one is on systems of power, the second is on physiological pathways, the third is on individual factors, and then the last one is on relationship and networks. And what I'm hoping that you get out of today is a reasonable framework that will help you not only acknowledge, but also address and respond to oppression as part of everyday product development lifecycle, because it's not a one-off process. It's more of a continuous quality improvement process. And so to begin and show you an example, I wanted to first walk you through the toolkit, and then I'll show you tactical examples of each of those 4 spheres and the opportunities that I saw with our teams of how we walk through that. I'll link below in the chat a little bit later on how you can access this toolkit. A few frames of references is that we worked with a team of amazing volunteers just to produce this toolkit. And I have to acknowledge the amazing work with one volunteer. Her name is Hidemi Nagaupek, who's also a public health researcher and an amazing advocate. And she is actually one of the key leaders who created a section for key population consideration. And because of this section, we've gotten a ton of engagement in terms of translation and transcreation with both Gov partners, but also NGOs and nonprofits because of this work. So a few examples is that we start off with a framework of the health equity. which I'll dive into in a little bit later after I show you this toolkit. The other one is the research that our amazing volunteers have actually done, including ones we've done on personas. This has been really helpful in informing our Gov partners about the types of population segments, as well as personas, about who adopts and who resists vaccinations in the United States. It also includes the work of third-party trusted sources and organizations who are also currently doing that work, including mental models about how they started doing and looking for information, which is not just applicable to COVID-19. It's a really good use case for even childhood vaccinations and immunizations of how parents navigate. We also have social media, which we applied and super cool for a county called Pueblo County in Colorado, where they used a ton of these themes and examples that we generated into their social media. And I'm super excited to just show our team later on of how this looks like. Another one that people have said that is really helpful is this checklist that I've introduced really early on. It's a mashup between what the government has created from health literacy as well as our own design thinking. And there are these 4 frameworks, which I'll walk you through in depth in a bit, about the 4 quadrants that I've mentioned that impact health equity and the types of how might we's that really helped our own team understand our own biases, but also help uncover opportunities for equities. And there are also examples of case studies here for Gov partners that we have done. And the most important one that has really gotten a huge hit is definitely messaging examples from different third party, but our own work of messaging that we have on social media, which we have open sourced. It's in Figma, which will show up in a bit, that anybody can use, and our own content guidelines. This actually is in effect right now in Pueblo County, as I mentioned, which they've had a tough time with mask hesitancy at the start, especially in March and April, which they are currently using. And we're also implementing this with Mesa County this summer, especially since they're one of the lowest vaccination rates in their state, roughly around 39%, while the state is around 62%. And we're helping them with their own communication. So there's a ton more of templates that you can look at that we've used, and we've used components for other websites and other Gov partners, which I'll show you in a bit, as well as icons. And you can read about the work that we've done here for information for key population consideration and other special topics that were very helpful in terms of determining the course of communication, both digitally, but also offline. So with that in mind, I want to walk you through not just the toolkit, but also the core frameworks that helped us think about them. The first one is on systems of power. These are the types of policies, processes, and practices that both help promote health equity, but also they can intensify health inequities, because it allows like unfair social, economic, and even environmental advantages. So the things that I wanted to focus on here when we approach these projects, especially during project scoping and in planning with our team when we had our kickoff call, is that we wanted to understand who are the core players in the room and what are the types of balance of power that we have and they have, and how do we share or give up power. So the first question I tend to ask is like, what are the types of power systems that prevent or even accelerate people's access to information, but also to action? So one question and opportunity I ask is, how might we shift the balance of power? How might we ensure that we center our collaborators over our funders? And this was key. And I'll show you an example in one interview that we've had with residents in terms of antibody therapies that was very helpful. And then the third is, how do we ethically involve people in the co-design, data collection, research process? And so a few options that we've done this, and you might have seen this examples in the past, so I'll brush through them really quickly, is that we gave people power back, reducing their anxieties about what to plan and what to collect. This was actually very important for undocumented workers, actually, especially those who don't have traditional forms of IDs. And initially, the state of Arizona, when we supported them on this project for their vaccine patient portal, they didn't have those options. They didn't even have options for cost or information for parents and children, which we had. So we want to give back residents and even non-residents that power back. It also looked in terms of explaining why collecting your birth gender was it important versus your preferred gender, as well as options for inclusive gender categories and ethnicities. It also means really addressing costs, which is the biggest importance with immigrants, and acknowledging our customers and also their own residents and constituents, what it means to live in multi-generational homes where they need to print and they can't just email a vaccination appointment. It also means that we had to rethink about who do we bring in our volunteer team, bilingual, multilingual speakers, those different diverse backgrounds who represent, in this case, Mexican, Spanish dialect was key to transcreate other areas within the vaccination appointment scheduling system to reflect the residents. And same thing on the second point is on relationship networks that bears power. We've seen that a lot of relationships and networks, they intensify health inequities. And we saw that with our Gov partners and NGOs, where they really wanted to understand what are the types of social networks that potentially enable health harming behaviors. So one question to think about is, what relationships do people value the most so that they can feel safe, protected, empowered to make the right healthy decisions? How might we amplify the voices of hyperlocal community, but also how do we design processes that empower people and create a sense of agency in them? And that means for us, when we worked with the state of Connecticut, is to really understand the trusted messengers to reach the Hispanic population. And we realized from our own research that immigrants and their families don't necessarily form a relationship with the government. They actually have communities outside of it. And we recognize this important bottom-up approach for hyper-local focus outreach with CBOs and, the decentralized outreach of vaccine response to the community. And a lot of them tend to centralize in news outlets, even local organizations, friends and families. So we've seen our Gov partners who've done pretty awesome work in terms of launching ads on Spotify to reach young adults for their vaccination education. We've seen innovative partnerships with public libraries, especially in rural communities where libraries are often the fastest internet connection in town, alongside with the highest digital literacy to assist users. So those are just a few examples of relationships and networks. Other ones is that we also fostered relationships with nonprofits and NGOs. One that we have created a partnership is with Epicenter NYC. This is not our work, it's their work actually, but this is an example of how they open sourced everything, including one, they had a Google Drive folder of template employee letters of multilingual languages to support undocumented workers and who typically receive like untraditional forms of salary, like cash on their table. There's a second image here. This is with the University of Minnesota, where they've partnered with Native American communities. And that's one example of one that I've also recommended with other state partners who are working with the Navajo to be able to outreach to access vaccination. And then there's other one where this is a comic in Spanish. It's an example of a telenovela comic, which we are also considering for empowering children and youth with Mesa County as we create them for their social media outreach. The third element of this health equity toolkit and framework is individual factors. And individual factors means anything that can impact health inequities through attitudes, skills, or behaviors. And it can also impact the community. So how do we learn continuously from the people we serve and make sure that we establish them as experts? So how do we lead with transparency and share data insights transparently, and make sure that we recruit diverse teams as we show them. So here's a few examples. This is one that we've done with specifically in a concept testing session with the state of Arizona, where we were trying to understand specifically what are the types of sentiment trying to get into booking a vaccine appointment. We also did listening session with multiple other counties and states. The common sentiment that we've got from them is that we learned that it's a space for healing, and that a lot of our participants have trauma that's outside of their social circles, and they don't want to share that except even with us. So our sessions really combat loneliness, and sadly, we've all participated in a global communal traumatic event. And so we realized this with our equity toolkit. What we've done is that even though we have our own checklist that helps us understand how we design best practices at websites and products, we also have our own internal checklist with our team to do check-ins with each other about what we've learned of micro insights, about what it means to decrease re-traumatization for our participants. And we really respond. We don't pathologize. We understand the percent of what makes them reduce anxiety, as well as to listen to their stories, to their sensory fragments, so that we can respond to that. We also reduce structural barriers with them in terms of their systems of power. So a lot of our partners have innovative compensation models. So we don't think in terms of compensating in terms of money. It's also compensating for the value that they bring and their emotion. So they partnered with WIC, SNAPS. Right now we're part with Mesa County in terms of a different compensation model as part of a grant for their health equity team, where we're not just compensating in money, we're also compensating for transportation as well as gift cards. And another form of individual factors is our work also with Mesa County in Colorado, where we think about the different ways where we can highlight action, especially for those with low digital literacy. And in this example, on the left is the before. It's not very actionable, while on the right, we have specific cards that highlight and reflect the residents that we are serving. In this case, it's a diverse population. We also have clear action steps to sign up or to learn more on the vaccine, and bilingual translation that we also supported in helping them. And another example here, this is in Tagalog. This is with Healthcare Ready. It's an NGO nonprofit organization that supports also in terms of disseminating information in healthcare. And this is specifically with supporting with antibody treatments and therapies for COVID-19. This is especially helpful for their COVID-19 testing partners, where a lot of people are not able to take the vaccine because of pre-existing conditions. So we've done a ton of concept testing, both with patients and healthcare providers, and we really uncovered a lot of inequities. One of them is that, the original people who wrote the scientific information didn't think about writing about cost or about simple language that really translates into different factors that impact high risks like obesity, diabetes. People don't know what BMI stands for within patient population. So that's one thing that we help them reconstruct as a reference point. And this is with Vaccinate the States. It's a collaborative effort that we've done with a community that does a lot of work. They pull a ton of vaccination locations, probably most comprehensive nationwide, where they also pull with vaccines.gov and also called it Vaccine Finders. And this is in Arabic. We've translated up to date and transcreated up to 6 languages, including Arabic, Tagalog, English, French, Spanish, as well as German. And soon next week, we'll have Chinese simplified. The last one I wanted to pause here is on physiological factors. This is where we have factors that intensify because of a person's environment or impaired physical state, cognitive or psychological. So how can we accommodate or even challenge structures that exclude people from participating, not just in public spaces, but also in digital spaces? So how might we design for a commitment for them to recover? And then number 2, how might we address imbalance power dynamics? And lastly, how do we create and support somebody's sense of physical and psychological safety. One way that we did that is that when we worked with Pueblo County in Colorado, when we first did an audit of their vaccine resources, but also COVID-19 testing resources webpage, a lot of things were not accommodated for a mobile first approach. And we also learned from anecdotes from their elderly population that one, a lot of them did have a lot of physical disabilities. One of them, they had have motor disabilities, including Parkinson's. So their touch points on mobile was very difficult. When I worked and volunteered this year in as an EMT in a mass vaccination sites, I was working with adverse reactions for patients, and a lot of patients were representing other patients who had dementia. And so their cognitive ability is no longer there. And the reason this image on the left is problematic is because we have a page concocted within a page. And if you can see that in a mobile view, it's pretty difficult for focal points for people to see. So we rearranged that so that it's clear, it's text-based with links, and it's straightforward. So that's just another way to advocate based on anecdotes we've seen with the elderly and those with disabilities. And speaking of disabilities, we make sure if we are developing any web pages for our Gov partners, and this is with the town of Amherst in Massachusetts, that we align based on best practices for WCAG 2.1 or 2.2, as well as ARIA and any other best practices that we could find in compliance with 508. And this is just one example that we pulled of how we improved roughly on like 30 plus issues we found for accessibility, and it has launched and there are no issues so far from this. So a few lessons learned I wanted to wrap up before we have an informal discussion is that all design, research, even data, analytics, and development can be equitable. So that means that your interview guides, how you collect data, and even how you frame communication can be equitable and should have equitable language. And number two is that equity should be part of an infrastructure and a community, and it can show up in teams. So this means from project planning to closing to even setting up an equitable compensation model to that resonates to even de-identification protocols that protect your participants' stories is absolutely possible. And it should you should have think about that from the start, because your participants and the communities that are impacted the most by movement should have a prominent place leading the movement. And the third point is that there should be a continuous process of learning, disaggregating data, and questioning assumptions, and bringing the right experts. And we did that in a lot of the projects, whether they're clinical experts or just regular everyday citizens, or even employees that work in state or local government who needed to provide their expertise. And it requires us to build a relationship. So it's not a one-off process during a research process. And then the fourth thing is validate inequities in teams. Tomorrow, we're launching USDR's user research playbook, which includes a really short exercise for teams to recognize bias. It's essentially a very short form in Google Docs where it can allow you to recognize different forms, reference points, including if you have broadband access, internet access, how fast or how slow it is, or other forms of references, so that you understand how you are communicating the assumptions you have versus the communities that you are trying to serve. And it also includes information about what the context when your participants experience inequities, maybe a few questions in addition to our research project plan. Where did your residents as well as your Gov partners have they turned to for help outside of their own community? And the last thing I wanted to share with you is that you can absolutely implement equity responsive practices and policies. And this means in your scoping calls, really understanding the barriers for entry and re-engagement in a service for the people that you're serving, moving away from resilience, which is a privilege, to addressing systemic failures for the longer term. But also when you're interviewing new team members coming in, whether they're volunteers or not, we assess for an equity-focused approach, at least a baseline understanding, so that we're all on the same page and we're building and sustaining a culture of the trust that supports our own team members as well as the first step. So excited to share with you that research playbook. And there are a ton of more resources that you can access here, as you can see on my screen. And wanted to pause here to see if you have any questions, comments, initial impressions, and anything that you wanted to comment on.